Good morning, everyone. Good morning, Chairperson. Uh, this topic is we commonly encounter during our OPD, and it is very common. Okay. We commonly encounter this disease in our day-to-day practice. But what we commonly encounter is rifampicin sensitive tuberculosis. Today we'll discuss what happened when we encounter drug-resistant tuberculosis in our OPD. So, prevalence of acute TB is among the solid organ transplant is 1.2 to 6.5% in the developed countries, but it is increased to 12% in endemic areas like India and Asian population. So, incidence of tuberculosis at least 4 times to the general population. In some studies, it's nearly 30 times to compared to the general population in our transplant patients. So, in most cases, active TB is thought to arise from the reactivation of latent tuberculosis or previously untreated primary infection. So, most of the cases are presented within the first year of the transplantation, and the median time of presentation is around 6 to 11 months. These are the common risk factors in the solid organ transplantation. The first, most common is a history of untreated tuberculosis. Presence of finding of chest radiograph suggestive hill tuberculosis. Commonly use T cell depleting antibodies also increase the risk of tuberculosis. Longer hemodialysis vintage in renal transplant patient. Hepatitis C virus infection also increase the risk of it. And among the organ transplantation, the lung transplant recipient has the greatest risk of active tuberculosis. And older patient, as we all know, is highest risk of tuberculosis. So these are the studies done in India, which shows the pattern of organ involvement in post transplantation. Studies done Agarwal et al., John et al., and Sakhuja et al., which shows that most bulk of the patient are pleuropulmonary pyrexia of unknown origin or disseminated tuberculosis. So how to diagnose this? We commonly practice is we used to do a gene export for and check for the rifampicin resistance, and which is a cartridge-based nucleic acid amplification test, which simultaneously detect the tuberculosis and rifampicin resistance, and we go ahead with the therapy. But there is more to it, and we usually don't check is expert gene expert method to check for other drug resistance, such as isoniazid, fluoroquinolones, second line injectable, and ethionamide. We other methods are line probe assay and liquid culture. Soil culture method now we are don't use because of the longer turnaround time, and it is more cumbersome to do. So line probe assay is a PCR and a reverse hybridization technique which interpret based on the development absence of wild type or mutation type bands. And liquid culture is usually used to monitor the monitoring of the treatment response. And one other test recently added is 2NET, which has a turnaround time of around 1 hour only, which is used as a point of care test and which is easy to do. So these are the different definition for drug-resistant tuberculosis. If patient is resistant to isoniazid and susceptible to rifampicin, we call it isoniazid-resistant tuberculosis. If patient is rifampicin resistant, then there are three subcategories: monoresistance, polyresistance, and MDR and XDR tuberculosis. In case of polydrug resistance, patient is resistant to more than one first-line drug other than isoniazid and rifampicin. In case of MDR tuberculosis, patient is resistant to both isoniazid and rifampicin with other first-line drug antitubercular drugs, which include another subset is pre-XDR TB and XDR tuberculosis. In pre-XDR TB, patient is resistant to isoniazid, rifampicin plus fluoroquinolones. And in case of extensive drug-resistant tuberculosis, in which patient is resistant to isoniazid, rifampicin, fluoroquinolones plus additional group A drugs, which is bedaquiline or linezolid. So in a common routine practice of transplant patient, we used to do the gene expert rifampicin sensitivity check for rifampicin sensitivity. If patient is rifampicin sensitive, we go ahead with the HRZD intensive phase followed by continuation phase. HRZD for intensive phase, HRE for continuation phase. We used to afraid of interaction with tacrolimus and rifampicin commonly. So we replace rifampicin with moxifloxacin in case of less severe pulmonary tuberculosis and other tuberculosis. But if we are using moxifloxacin in place of rifampicin, then we have to continue with the 4-drug regimen. And the clear catch is here in the duration of therapy. There are no specific guidelines for the solid organ transplantation tuberculosis treatment. So common practice is we used to do is a treatment duration of 9 to 12 months for pulmonary tuberculosis and 12 to 18 months for extrapulmonary tuberculosis. Where this come from? It is based on the study shows that if the duration is less than 9 months, it will increase the mortality risk, while therapy for more than 12 months is associated with no recurrence. So minimum 12 months of therapy we give in the solid organ transplantation. Now, this is a common practice we used to do, but what happens when we encounter the resistance to the drugs? As there are no organ transplantation guidelines, we have to follow the National Tuberculosis Elimination Program. In that, we send us for the resistance for the rifampicin, isoniazid, fluoroquinolones, and other drug as needed. If we encounter the rifampicin resistance, then we have to check for the eligibility for BPAM regimen. If patient is more than 14 years and there are other eligibility criteria is fulfilled, we go ahead with BPAM regimen, which is a treatment of choice in rifampicin resistance tuberculosis. If patient is not eligible for BPAM regimen, then we have to go for the 9-11 month shorter oral regimen. If patient is not eligible for this method regimen as well, then we have to no other option other than 18 to 20 months of the longer oral regimen therapy. Suppose this patient is rifampicin sensitive, and then we have to check for the isoniazid resistance. If patient has isoniazid resistance, then we have to replace the isoniazid with levofloxacin and continue the treatment for 6 to 9 months. If a patient has a no isoniazid resistance, then we have to use conventional therapy. These are the different 4 regimens we are using currently for drug-resistant tuberculosis. So first we discuss the treatment of choice for rifampicin resistance or MDR tuberculosis is 6 to 9 months of BPAM regimen with shorter oral regimen. So usually since bedaquiline resistance in India is very low, so we don't need to wait for the drug sensitivity test to come. We can start go ahead with BPAM regimen, followed by when drug sensitivity test is available, if there is a resistance, we can change accordingly. The problem with bedaquiline is the longer half-life. If calculated half-life is 24 to 30 hours and terminal half-life is 5.5 months, which is a problem. If a patient is taking a BPAM regimen and suddenly stop the medication, the other drugs will be cleared out from the body, but bedaquiline will remain for the longer period of time, which will increase the risk of resistance in future. So it should be given with strong monitoring, with minimum 6 days per week given with monitoring. And at the end of the treatment, administer at least 85% dose under the direct physical supervision of the treatment supporter. These are the inclusion criteria. As we all know, the 14 years and above, we can give BPAM regimen. As less than 14 years, we don't have data for bedaquiline, so we are not currently using it. Other thing is history of the drug exposure. Patients should be exposed to bedaquiline, linezolid, predominant for less than 1 month. If patient is exposed to more than 1 month, then we have to check for the drug sensitivity before prior to starting the regimen. And third thing is QTC prolongation. The moxifloxacin the highest risk of QTC prolongation, followed by bedaquiline, and then predominant and linezolid. If patient has electrolyte abnormality, then we have to correct it. Then followed by we check for QTC. If QTC more than 450 or more than 417 female, then we cannot use this regimen. In pregnant and lactating woman, we also cannot use BPAM regimen. So if a patient has significant liver dysfunction, SGO-TH with more than 3 times upper limit of normal and total bilirubin more than 2 times upper limit of normal, then we cannot again use this regimen. In case of extrapulmonary tuberculosis like CNS TB, spinal TB, disseminated TB, we cannot use this regimen. In patient have extensive pulmonary tuberculosis, we can use BPAM regimen. Significant cardiac conduction is also a contraindication for the BPAM regimen. If patient has electrolyte imbalance, then we have to correct it prior to check for the QTC interval and go ahead with therapy. These are the relative contraindications. If patient we are using strong inhibitor or inducer cytochrome P440 for P44 enzyme, then we again cannot use a BPAM regimen. Drug that can prolong QT interval, there is an interaction with it. And most important for our patient is concomitant use any of this drug that can induce myelosuppression. We are commonly practicing MMF and azathioprine. So this can be a problem in our patient. If patient serum creatinine is more than 3 times upper limit, this is also relative contraindication, as there is a chance of electrolyte abnormality is very high, so we increase the QTC prolongation and there will increase the risk of arrhythmia. These are the regimen. Bedaquiline usually 400 mg once a day. If after 2 weeks we go ahead with 200 mg 3 times a week. Predominant dose is 200 milligram per day. Linezolid we all know 600 mg once a day. Moxifloxacin 400 once a day. There are no weight band wise dosing. This is a fixed dosing we used to practice. So dose modification, bedaquiline, predominant moxifloxacin is not recommended during the treatment. If patient is intolerant to fluoroquinolones, then we have to stop drop moxifloxacin and go ahead with the BPAL treatment and extend the duration of therapy to 39 weeks. And most common toxicity is occur due to linezolid toxicity. One of the most common is myelosuppression, which is often reversible. If a patient develops anemia or thrombocytopenia or leukopenia, then we have to short 1 to 2 weeks of drug holiday and followed by reducing the dose to 300 milligram per day. Peripheral neuropathy is a common linear toxicity. In case of grade 2 and grade 3, we have to stop the medication for 1 to 2 weeks, followed by we start with the lower dose 300 milligram per day. In case of grade 4, we have to permanently suspension of the linezolid required. Some cases we can try 1 to 2 weeks of holiday and decrease the dose, but most of the time we have to withhold the medication. If patient has optic neuritis due to linezolid, permanent discontinuance is required. So if we start linezolid and within first 9 months, first 9 months, if we have to stop linezolid, then we have to consider treatment failed and we have to go ahead with the other regimen. If after 9 weeks of treatment initiation, patient develops linezolid toxicity, so say all efforts would be made to continue linezolid at full dose for 39 weeks, 26 to 39. If we have to reduce the dose to 300 milligram, then we have to extend the duration to 39 weeks. So after we start the BPAM regimen and baseline drug sensitivity test result will come with resistance to any of the resistance to bedaquiline, pretomand or linezolid. We have to label it a treatment regimen change, and we have to go ahead with 18 to 12, 20 months of longer oral XDR tuberculosis regimen. Follow-up will be done at 9, 13, 18 weeks and so on. But if the 9 weeks of therapy patient deteriorate or there is no improvement, or we have to repeat the same smear, repeat molecular test and culture drug sensitivity to all drugs at 9 weeks. Extension from the 26 to 39 weeks required if the linezolid dose is reduced to 300 milligram. In case of grade 3, grade 4 intolerance to moxifloxacin, we have to drop it and continue with other medication, and treatment may be extended to 39 weeks. It should be done with strict clinical evaluation, smear and culture microbiology follow-up at monthly intervals required. So second regimen is 9 to 11 months shorter oral MDR rifampicin resistant TB regimen. So usually preferred in the longer less than 14 years of age children, and eligibility criteria as rifampicin resistance should be detected. Patient should be fluoroquinolone sensitive. In case of exposure to bedaquiline, riboflox, clofazimine, linezolid should be less than 1 month. There should be no extensive tuberculosis such as bilateral cavity lesion, radiographic lobe of collapse, and more than 3 zones with cavities and 6 radial zones. We cannot use this regimen. We have to go ahead with a longer regimen therapy. Non-severe form of extrapulmonary tuberculosis we can use, and in case of a non-pregnant and pregnant woman is less than 24 of gestation is willing to MTP, we can use this regimen. In short, in pregnant female, we cannot use this regimen. So 9 to 11 months, the first is the intensive phase followed by continuation phase. In intensive phase, we 2 months of linezolid, 4 to 6 months of levoflox, clofazimine, pyrazinamide, ethambutol, high dose isoniazid, and 6 to 9 months of bedaquiline, followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. If some reason we cannot use linezolid, we can go ahead with replace with the ethionamide. After 4 months of intensive phase, we check sputum smear microscopy. If patient is positive there, then we have to extend the intensive phase for maximum 2 months. And we have to send first line line probe assay and second line probe assay, culture and drug sensitivity test should be done. If patient has additional resistance to pyrazinamide or in the baseline sample, and patient is resistant to fluoroquinolone, INHA or CATG mutation. So in that case, we have to initiate a longer oral XDR tuberculosis regimen immediately. And if we have to extend the intensive phase for more than maximum 2 months, then bedaquiline can be extended to up to 11 months. During the regimen, if patient missed the dose of linezolid up to 14 days, the missed dose may be added at the end of the 2 months. For some reason, if a patient we need to discontinue linezolid within the first 2 months, then linezolid should be replaced with 4 to 6 months of ethionamide. If patient is unable to tolerate pyrazinamide and ethambutol in continuation phase, drop one medication, continue rest of the medicine for the treatment duration. If patient is unable to tolerate more than 2 drugs or any of the bedaquiline, moxifloxacin, linezolid or clofazimine, consider the treatment failed and we switch to longer regimen therapy. Now, if a patient 18 to 20 months of longer oral regimen therapy, we need to start with 5 drugs from group A and group B. Group A is core drugs, group B is second choice, and group C is add-on drugs. So ideally, should be start with the 5 regimen from group A and group B. And in the continuation phase, after 6 to 9 months, we have to go ahead with the 4 drug regimen from group A and B. So we need to start all the 3 group A regimen if possible, and group from at least 1 from the group B. If we cannot use all the group A medication, we have to add both the group B medications. And group C is be added if we cannot use all 5 from the group B, A and B. So bedaquiline is limited to 6 months. We have to extend if patient we only use 2 out of the 5 drugs available from group A and B. Adequate number of group C are not available due to high background resistance, non-availability, and unreliability of the drug sensitivity test. In children less than 5 years, we have to replace the bedaquiline with dilamanid. This is the regimen for isoniazid mono or polydrug resistant tuberculosis. In that case, if patient develop isoniazid resistance, we give to 6 to 9 months of leoflox, rifampicin, ethambutol, and pyrazinoate. There are no separate intensive phase or continuation phase. We can extend the therapy to 9 months in case of uncontrolled comorbidities, extrapulmonary tuberculosis, if smear at the end of the 4 months is positive and when regimen is modified. Suppose we cannot use leoflox or pyrazinamide from this, so we have to replace with linezolid, or if linezolid cannot be used, to add clofazimine plus cycloserine. If both leoflox and pyrazinamide can't be given, add 2 out of 3 drugs: linezolid, clofazimine, and cycloserine. If rifampicin resistance detected, we have to change the regimen accordingly. After starting the treatment for H mono or polydrug resistant tuberculosis, probable MDR we consider as if there is no response to treatment and there is no resistance to rifampicin, we have to consider as probable MDR tuberculosis, and we have to start regimen from BPAM or shorter or oral, longer oral regimen. So we are most afraid of the drug interaction in our patients. We all know what rifampicin can do. It decreases the immunosuppression level, 2 to 5-fold decrease in the CNI level. So we have to monitor immunosuppression level. But if we are using linezolid, there is an increased risk of myelosuppression, and our patients are mostly on morpholate and azathioprine. So we need to monitor WBC and platelets. There are few articles on the clofazimine and predominant with drug interaction, and both drugs are moderate to strong inhibitor of cytochrome P450. So increase the CNI toxicity risk, and also predominant cause myelosuppression. So when we are using with morpholate and azathioprine, we have to monitor WBC and platelets. These are all the references. To conclude, we need more data on the MDR tuberculosis in our patient, because we don't have a specific guideline for it, and we are not aware of the drug interaction with the bedaquiline and predominant with the CNI morpholate. So we need more data to that. Otherwise.